Good afternoon, everyone. Once again, my name is Manone Rantekoa. I welcome you all in today's session. So by participating in this session, you're consenting to be recorded, and recording is done mainly for educational and quality improvement purposes. During the ECHO session, please remember to do the following. Do not share identifiable patient private health information. Please mute your mic to minimize distractions. Keep the camera on throughout the session if possible. And if you want to ask a question or make a comment, indicate by raising your hand. Alternatively, use your chat box. If you encounter technical challenges during the ECHO session, please contact our IT officer on the number indicated. So today we're going to discuss overview of palliative care and have special consideration for cervical cancer patients. And objectives are as follows. At the end of this session, you should be able to demonstrate an understanding of palliative care, its relevance and application, and also understand the WHO key facts about palliative care, also understand the scope of palliative care and who can provide it. And lastly, identify the goal of palliative care for cervical cancer patients. So today we are joined by our subject matter expert, Tebello Lepheane, who is currently working as the palliative care nurse, and she's also the founder and the CEO of Starlight Voices of Hope Hospice in UK and in Lesotho. Malichaba holds BSc in palliative care and is currently pursuing MSc in palliative medicine for healthcare professionals. And her experience is providing care in limited and high resource settings. She has worked here in Lesotho, in Puntu, and then in UK. And then she's passionate about charitable work. And like I mentioned earlier, she's the CEO and the founder of Starlight Voices of Hope Hospice. So she will be taking us through the session today, the palliative care session. And but before we hand over the session to Malichaba, who's our subject matter expert, we're going to stimulate our brains with a poll question. The poll question which says, palliative care aims to prevent and relieve suffering through the early identification, correct assessment and treatment of pain and other problems. If you are in agreement with the statement, you will select option A, which says this statement is true. If not, you will select option B. First poll says palliative care aims to prevent and relieve suffering through the early identification, correct assessment, and treatment of pain and other problems. Is this statement true or is it false? Please submit your responses. The poll has been launched. And please, all of you participate in the poll questions. Malichaba, I hope you can see the responses from your side.
Yes, ma'am. Yes, ma'am.
Okay. So for the sake of time, we'll end the poll here, but 92% of the respondents are saying this statement is true, and 7% is saying this is false. So we'll proceed with the session. Over to you, May.
Thank you, Manone. And thank you, everyone that has been able to connect on this call. It is a great moment that we appreciate the Starlight Voices of Hope team, because indeed this is a privilege and honor indeed to join you on this call. To us, it's quite an emotional time as well to have broken through this territory of actually delivering it through our own ministry, not just in any other setting or countries. It's a D-Day. So we give the glory to the one that has given us the vision, the one that is coordinating and orchestrating the steps, and indeed that has given us the favor to be considered for this privileged platform. Therefore, may I want to thank everyone that has been behind the scenes to actually coordinate and make this call a practical thing for today. So I'm grateful for the time we're going to share together, and I hope by the end of the session, we'll have achieved the objectives as you have spelled them very rightly there. Thank you, May. So I think the land that you see on the picture, it is what we have been graciously given to actually put our footsteps on the mark. And that will be happening soon by God's grace. So in this session, we have to also try and establish what does our umbrella body say, an international body that governs what we do. World Health Organization definition was first established around 1998, but was then revisited 2002, establishing that palliative care is an approach that improves the quality of life of patients and their families. As we are very much aware that anybody within the life-limiting condition or life-threatening issues, they have got multi-dimensional challenges. And I'm grateful because the answers that were on the poll, it just shows like my job is already done in there. So I might as well pack my bags and go because they have really responded very beautifully. Next slide, May. Yeah, thank you very much. As a continuation of the definition, in palliative care, we say it's not just about the end of life or the last hours or weeks or months of life. It is definitely throughout the journey, from the point of diagnosis. We have to try and identify and assess the patient's needs in a multifaceted way, physical, psychological, spiritual and socially, so that we can prevent any challenges and be able to address them accordingly. So there's also a definition again for pediatric palliative care, because it was noted that the earlier diagnosis, the earlier definition, somehow it was more to the adults. And then there was one that was developed for children. And it says it is an active total care of the child's body, mind, and spirit, also involving the family in that whole plan. So here we have got Naledi. I don't know, maybe some of us knew about Naledi, who had challenges. She was born with HIV. In the end, she was admitted in Children's Hospice in Bloemfontein. I think she died in 2017 or so. And she had renal failure. There she was having dialysis in Bloemfontein. So those are the people that walked the journey. But otherwise, the next slide, May. Here is just to really say, in palliative care, you can never do palliative care unless you really have exercise the passion and a compassion for the people, not just the job to get you paid and pay the bills and the electricity and pay children's school fees. It has to be from within, because you give so much for the little coming your way. It is about thinking for others beyond the needs you see. It's about exploring how best you can meet them and identify, and even advocating for them to have for the best care possible. So there I was visiting one of the patients. She was from the other further district in the north, and she was in Maseru in 2019, being looked after by her daughter. And I visited because most times when I'm in Lesotho, 90% of my time is about starlight. And definitely we don't have to make a difference because we are loaded. It has to come from the heart, and that is all about palliative care. Don't have to be brilliant, rich, or beautiful, or even perfect, but you just have to care. Next slide to me. Palliative care is all about living as much as possible, but it also involves end of life or comfort care or supportive care. That is in a case whereby it is quite challenging to hope for a reversal of the condition, but then it's just to make somebody comfortable as possible. In that picture, we have got Professor Stephen Hawking. Most of us will know. He was a great physicist that was in Cambridge here in UK. And around 22 years of age, he just discovered he was falling more often. He was still studying in Cambridge. And then he was later diagnosed with a motor neuron disease. So it means he had palliative care for 55 years because he only recently passed away around 2018 or so. And it just shows you that we have to identify the needs of the patient earlier and be able to attend to them on time. Many people think palliative care is something towards the end of life or only days or weeks of life, but it does indeed improve quality of life. It does not hasten anybody's death, but it just improves their quality of life so that they face all these challenges in a better way and they can tolerate them, managing their pain, managing other symptoms. And it starts as long as we have identified that diagnosis, whether it is alongside the curative treatment. Probably somebody has been diagnosed and going to Bloemfontein. We can start the journey there, manage their symptoms, provide psychosocial support and counseling, whatever it is doable. And again, it just makes us realize that that journey has to be identified as early as possible by doing the proper assessment. Next slide, please, May. Then there's a great question again, who can provide palliative care? Each one of us is able. As long as we are operating within the health and social care space, we are actually part of the multidisciplinary team. The team of doctors, nurses, pharmacists, the team of social workers, occupational health therapists, physiotherapists, anybody within that space is able to provide a palliative care. You don't have to be a specialist to be doing that. That is why Project ECHO, the model of Project ECHO is about all teach, all learn. We have got all that knowledge that we can exchange and empower each other. At the end of the day, it's moving knowledge to people instead of people moving to when the knowledge is found. But we deliver all this training to decentralize knowledge, to empower each one of us, so that in any setting that we operate from, whether it is in a community setting, in a hospital setting, or even in the intermediate setting, whether it is a daycare center when we have one, or hospice, we can be able to approach the palliative care within the means that we operate from. So it is palliative care approach for everybody, but then we narrow it to the general principles whereby people are more empowered with the advanced palliative care programs. But then when the complexities of patients' challenges are enormous, then the specialist team, or for those that have done palliative care, whether doctors or nurses or pharmacists, they are now involved. Next slide, May.
So we have poll question 2. You may take a break, Tebello. So poll question 2 says, the scope of palliative care includes end-of-life care and euthanasia. Is this correct? Is it correct to say that? The scope of palliative care includes end-of-life care and euthanasia. Please submit your responses, colleagues. The poll has been launched. Are you in agreement with this statement? Are you able to see the poll question? I don't.
Not at the moment.
Not at the moment, because I don't see.
Oh yeah, I see.
Oh,
yeah.
You're seeing it. Okay.
Yeah,
but
yeah.
I don't see responses, or are they being submitted through the chat box? Okay. I see other responses through the chat box. Unfortunately, the poll here is failing to launch. So we have Toloba saying, this is true. And then Musidi false, Merimu happy false, this one a lot true, and Mama Godi true, and this one a lot Rasisha was saying true. Kwena Makwai true, Mabatown true, Lisedi true. Majority are saying this statement is true. So they are saying the scope of palliative care includes end-of-life care and euthanasia. They are in agreement with the statement. So over to you, Tebello. Colleagues will hear what our subject matter has to say about this statement, whether it's correct or not. Over to you, Tebello. Thank you.
Thank you very much, May. It is indeed a wonderful poll, May, because it just gives us a wider range of what we can discuss, because palliative care is that quality of care provided on the patient's needs with or without the patient agreeing to the care in a way that they might not have identified their needs because they are not aware of what is available on the health service. But you identify the needs and you map up the plan and you discuss it with them. But in terms of euthanasia, it is an intentional taking away of one's life, whether they have got complications that could still have been managed well with the right medication, with the right symptom management plan, using all the essential medication as listed by World Health Organization. So it is different from palliative care. They might use the medications that are within the range of what palliative care would use, but it is it is a medical dilemma, but it is actually not palliative care, because that is an intentional taking away of life. Whereas palliative care, it is the general condition of the patient, the clinical level of patient's condition that will lead to progressive decline to the end of life, but not an intentional move to make end of life a reality. So that is where the difference is. And thank you for everyone that has responded. So those are ethical dimensions and legal frameworks. That's where they operate from. Here in UK, euthanasia is still illegal. Anybody that wants to be involved in it, they travel to Switzerland, where it is allowed and legalized. But on return, they are arrested. They are arrested. Anybody that took the patient to those centers for the purpose of euthanasia, by the time they come back, because those people will have died and they can't even answer back, then whoever took them to the flight or by any means, they are responsible for having supported that move. So they are arrested. Here we talk about the scope of palliative care, and we are guided by the World Health Organization Public Health Strategy for Palliative Care. It is all about consent, about if we look at this house with all these bricks on the sides, it's all about saying we need to be using the essential medications, which include opioids, morphine, and other essential medications to address the challenges of the patients who have got life-limiting conditions like cancer, renal failure, or any other. Then we have got, again, on the blue brick, education and training. But at the center of all that we are talking about, it's about somebody who has got palliative care needs. And we have to make sure that we integrate our care provisions to include palliative care in all the programs that we already have. Then it's got the foundation of research. We need evidence-based medical practice. Therefore, we have to be informed about the latest research and improve our health policies and empower the patients and communities of what is available on the menu of our services. So on the list there, I think I've said most of them, but one of them is about breaking bad news. How do we conduct those challenging and difficult conversations with the patients and families without taking away their hope, without leaving them with a depression and not even following up that initial conversation with a progressive counseling if there's a need. End of life care. It's about also addressing all the four-dimensional challenges of this group of patients, attending to their emotions, spiritual, psychosocial, even pre-bereavement or even the actual bereavement once the patient has passed on, and making sure we support their families as well. Next slide, May. This is the model of palliative care. There are different models out there, but this one is another one that has been updated in 2017, whereby now we no longer talk about palliative care starting at the point of diagnosis. But anytime there's already a concern about the symptoms or the clinical picture of what the patient is presenting with, from that moment when we started the screening process, sending them for scans, sending them for multiple blood tests, sending them for all the x-rays, already showing that we are very much concerned. Our body language, even the hints from our statements, it's already a journey that we should be approaching with a sensitivity, with a cultural sensitive approach towards breaking bad news, just gradually come with the patient on board, so that when the diagnosis confirms that there is a life-limiting condition, we are able now to break the ground, having built the rapport. Then when they are already going through their treatment journey, if there's an option for chemo, surgery, or even a radiotherapy, then we go through that journey with them during the curative treatment plan, by making sure that they are not experiencing distressing side effects of the treatments, or even the pain and other symptoms. So if indeed it shows that there's a challenge that even the treatment plan might not go as far as we had hoped, probably because most of our patients are diagnosed at a very advanced stage of their disease, then it's just now to focus on improving quality of life, ensuring that pain and other symptoms are addressed, and support the family. Then provide that pre-bereavement counseling, preparing the patient and preparing the loved ones. And if there's now an ultimate end of life imminent, that is when we have to ensure we have got adequate morphine. It is not just in the cupboard, it is actually available and accessible for the patient, so that they don't stay experiencing 24-hour care of agonizing and debilitating pain. And then when they have gone, then it is about bereavement care plans. Next slide, please, May. And tell me about the time, Manone, so I don't take too much. This is a global picture from the World Hospice Palliative Care Alliance here in London. They have done this, the world map of what the needs are worldwide. And it shows that 58%, 50.8 million people are estimated around the world to be requiring palliative care, as we say, from the point of diagnosis through to the end of life. And indeed, most of these people are actually found in the low to middle income countries. And this included those that are nearing end of life. Therefore, there's a great burden of this serious health-related illnesses. And the people that are suffering most are in the poorer or the developing countries. So that's why we have to prioritize how we invest in answering the needs of our patient. Next slide, May, please. Thank you. What do people want when they have an incurable disease? What do they really expect from us? They would like to be pain-free, have their symptoms well managed, so that they are not living in agonizing distress of pain or vomiting or constipation or sleeplessness or even depression. Then try to avoid inappropriate prolongation of the dying process by making sure that they are nursed and supported and provided with adequate medication to keep their symptoms under control. And again, they want to have this sense of control, that they can let us know what they want, what their priorities are, whether they wanted to die in hospital or at home, how they want to be looked after. And again, is to discuss those preferences, and actually even to tidy up their affairs, to plan well and relieve the burdens on the family by supporting them too, because they go under stressful situation and burnout. Thank you, May.
Thank you so much, Tebello. We have yet another poll question, which says WHO analgesia ladder for pain management has 3 steps for adults and 2 steps for children. Is this statement true or false? Colleagues, let us please submit your responses. WHO analgesia ladder for pain management has 3 steps for adults and 2 steps for children. Is this statement correct or it's not correct? Okay, I see the responses are coming through with majority saying this statement is true. Okay, but the responses are still coming through. We'll wait for a few seconds for others to submit their responses. Now, Malichaba, can you see the responses?
No, ma'am, not this time.
Okay. So for the sake of time, we'll end the poll here. But 89% of the respondents are saying this statement is true, while 11% is saying this is false. Yes.
Thank you, ma'am. Indeed, most of us think they got it. It's actually correct that it is 3 steps for the adults, and for children is 2 steps. Simply because with the adults, because they can communicate their pain issues, they can respond well to the pain assessment tools. We are able to gauge whether we have got an option of other medications that are involved in step 2, like codeine and adjuvants, like the amitriptyline for those that have got a nerve pain, and even including the anti-epileptic medication for those that are experiencing nerve pains. But for the children, because it is hard to communicate with them, sometimes they are just toddlers who are not able to express themselves of how this pain is, not being able to define all the characteristics that will guide the plan. So there's no stage 2 in children. It is just step 1 and the maximum, which is going to the opioids, that is step 3. To them, it will be step 2. Thank you very much, May. You can move to the next one. This one was for the adults. So this is where our children are. The little people in step 1 will be just showing the mild pain symptoms. The behavioral situation will express how we believe the pain might be, whether it is crippling them from playing with the other children, looking miserable. But then if it looks like the child is suffering a lot, that will be moderate to severe pain. So we go straight to the strong opioids, which is morphine, the liquid morphine or the long-acting, depending on the assessment of for that patient. So that is where we are with the little ones. The next slide, please, May. So the goal of palliative care is about improving quality of life, as we said, but improving that quality of life needs a constant review of the clinical picture of the patient, what their priorities are, and we really tailor make that plan as a person-centered approach, not just cutting one line of approach for everybody, because the people are individuals and they are different. So in a case whereby now the cure is no longer the option because it seems to be coming at the cost of other symptoms and systems are crashing down, the kidneys are failing, the liver is suffering, and even the lungs are really struggling, then it means that treatment plan might now have to be reviewed, discuss with the patient, break the news, and now change the lanes. Change from the outer lane of treatment and aggressive measures, but now move towards improving and prolonging quality of life for that patient, managing the symptoms, providing all the 4-dimensional approach of attending to their physical needs, psychological needs, social needs, and ensuring that their spiritual needs are attended. But if then even improving their quality of life seems to be a struggle, they can no longer really enjoy living because they are declining so rapidly, then we have to optimize comfort, ensure that they are having medication that manage their distressing symptoms around the clock. The next slide, May. This slide is just shifting us towards the idea for our presentation with the focus to cervical cancer. Here is only statistics that was showing around 2012 how many patients really managed to get referred to South Africa. It means this might be just a tip of an iceberg, because most times our patients are diagnosed at a very advanced stage. They will have tried the traditional doctors. They will have tried all sorts of concoctions that might have even taken all their savings. Sometimes when they are asked to go to Bloemfontein, they have to go back to the hidden pockets of our kingdom, where we know that it would be again difficult for them to come back to Sankatana and go to Bloemfontein with all those expensive traveling costs. Sometimes the hard Lemona Maseru as well Jesus Mongong might not even come back to actually be captured in these statistics. So these are the ones that are managed to actually be transferred to South Africa. And you can clearly see cervical cancer is actually responsible for over 21.3% that year. That is a major prevalence, and is still the same. Again, it is added by the fact that we know as a nation, we are number 2 worldwide in terms of HIV and AIDS prevalence. And that is another predisposing factor to an increase in numbers for cervical cancer. The next slide, ma'am.
Thank you so much, for that. So you may take a break again. So we're going through the case study. It says a 40-year-old female diagnosed with stage 3 cervical cancer, that is the metastasis cervical cancer with involvement of surrounding structures in the pelvis. And the presenting symptoms or chief complaints are as follows. The patient has severe pains, profuse foul-smelling vaginal discharge, PV bleeding tendencies, and she's underweight. And then medical and surgical history. The patient is HIV positive and was diagnosed in 2017. Since 2017 on ART, HIV positive and on ART since 2017. And the patient now presents with severe anemia, was referred to Sankatana 6 months ago, but did not go due to lack of funds for transportation. And then the family history says, and the social history. This patient is married and a husband works in another district, usually comes home month end, but since 3 months ago, he stopped coming home. And this lady has 3 children, 17 years, 12 years, and 8 years. He lost the job in the factories due to being unwell, and she couldn't continue working. And then psychological and family concerns are that the patient has severe pain, low mood, poor personal hygiene, lack of family support, low nutritional intake, loss of income, lack of spiritual support, and increased dependency level. And now, looking at this case, we're going to discuss what are the specific needs related to this patient. We have seen the history of the patient. What are the specific needs? Do you want to talk about it, colleagues? If you want to say something, please indicate by show of hand. Alternatively, use the chat box. This is the family history and the social history, and the diagnosis of the patient, medical and surgical history, 45 years old, stage 3 cervical cancer, presenting with severe pain, profuse foul-smelling vaginal discharge, PV bleeding tendencies, and weight loss. And she's on ART with severe anemia, couldn't go to Sankatana, where we know the services are being provided for cancer patients due to lack of transport fee. And then the family history is married, and now it appears like the husband is gradually abandoning her because for the past 3 months, he didn't show up at home. The children are there, 17, 12, and 8. She lost her job. What are the specific needs related to this patient? What can we say? Colleagues? You can unmute your mic and speak if you have anything to say. Alternatively, use the chat box if you you want to say something? Are there specific needs related to this patient? Colleagues? Pare Hospital, anything? Would you like to say anything, Pare Hospital? Okay, Neria is saying their financial needs. Okay, thank you so much, Neria. Okay. And then Ma'am African Spetla is saying the patient is in need of financial support and counseling. Okay. She's already responding to the second one. Okay. And then Matem Sioni is saying nutritional support is one that the patient is in need of. And then Neria Ramahata is saying social and psychological. And then Musiwa Mapetla is saying the patient needs financial support, psychological support, counseling, and pain management. And then Mepal Samucheku is saying the patient needs pain relief, nutritional support, and social support. Megan Dolini is saying end-of-life care is needed for this patient, psychological support, as well as nutritional support. So those are the highlighted needs of this patient in the chat box. So let us go, colleagues, to the second question. I know you have already touched on that. So what can be done to improve the quality of care or preserve dignity of this patient? We have seen how the patient is presenting. What can we do? So that is our second poll, our second discussion question. So Musiwa Mapetla is saying the patient requires family support. Zakaria is saying we need to provide support this patient with hygiene. So we need to make sure that the patient is hygienic for her dignity. And Mabashakwana is saying we need to support this patient with good nutrition and financial means. Okay, all right. So those are the responses that we have. Tebello. So maybe for the sake of time, we can stop here, but I see they're still coming. So maybe I can read these few that are coming through. And I saying the patient needs a hospice, maybe a new placement of the children for care. I think I got it right. So Mabafaka Namalapo is saying also palliative care is needed here. Leboha Moletsani saying refer to social worker for financial support. Kwena Makwaifi's psychological need, love and belonging, nutritional need, and financial support are needed. Memory Muhapi saying this patient requires psychological support. So those are the responses through the chat box. Maybe you may proceed from there and guide us so that should we come across a similar case, what is needed for us to do? Because we may not be practicing palliative care as is being said or detailed here. So we need to know what should we do if we come across a similar situation. Over to you, Tebello. Thank you.
Thank you, my colleagues, and thank you, Manone. All the answers are all correct. Because in palliative care, we talk about a total pain model. Total pain model is whereby we say the patient is a unique individual that has got multidimensional needs that needs to be attended to. In fact, the founder of modern palliative care was initially a social worker. Then when she realized she was not able to respond to the needs properly, that is Dame Cecil Saunders, she became a nurse. She still realized that she was not able to respond to the needs of the patient properly. Then she became a doctor. And then she started setting up a St. Christopher hospice in London. She was a multidisciplinary person in one body. And that is the approach that she founded Total Pain Model on, whereby we can identify the physical needs as my colleagues have said, it will be that smell, that is hygiene needs, that is pain issues, and other symptoms. And again, we go to psychological needs, whereby they have spoken about counseling and the support. They have spoken about spiritual needs and all the support that she will need. And they have also identified multifaceted social needs that will include supporting her and supporting the children, identifying what she can be able to cope with and how the children can be supported and taken care of. Whether it is in a hospice setting or ongoing palliative care, or escalating the issues to other government departments like social development. In the past, before 2012, we used to have clinical social workers in every hospital. But when the Minister of Health and Social Welfare went separate ways, we lacked that presence of social workers within the hospital setting. So much that the referral takes time for them to deal with the caseloads of patients coming from the wards. But the move for palliative care is to ensure that we have got palliative care teams within hospitals, that we have got the team of doctor, nurse, pharmacists, social workers, occupational health therapist and physiotherapist to identify all those multidimensional needs and deal with them in one go instead of the patient to be given medication in the hospital. Then they need money because they haven't got food. Then they will have to go and queue at the social development to get an appointment and to be assessed for the needs. In the meantime, they are unwell to even travel and leave the house. Again, we have just said this patient has got a profuse amount of vaginal discharge that is foul smelling. So indeed, we have to work together. I think in the meantime, as you asked me, if we face this kind of situation, it's just to explore the referral systems within your own department or district hospital, because there are social workers assigned to each and every hospital while we wait to have for their presence physically within the hospital compounds. But this is the situation in me, and hence why we are urging and advocating for these patients so that the social development is now working on ways of establishing how they can allocate people that will respond to the immediate and urgent needs of patients with life-limiting conditions like cancer, because we haven't got time in cancer. There's a word or statement that says, in palliative care, we haven't got second chances. We have got only one chance to get things right, because we are talking about time that is usually not on our side.
Okay.
Next slide, May.
Thank you so much, Tebello, for that guidance. So, colleagues, do you have questions related to this case? Are there questions that you want to ask Tebello before we proceed to the summary of key points? Are there questions, comments, inputs? Okay. So please do continue to submit your comments and questions through the chat box as we proceed to the summary of key points. Over to you, Tebello, to proceed.
Thank you, May. As we have actually identified, honestly, we have all been aware of the complexities of this lady's needs, because the husband no longer now financially supporting the family. So we might need to escalate that financial need combined with the social care needs to the social development, so that if they are able to get whether it is the short-term, intermediate, or long-term social grants, so the children can be provided with even the school fees, the support for their education. And again, another thing we need as a nation is to have for the chaplain service or pastoral counseling. It is only one hospital that we have so far, in my knowledge, in the country that has got a chaplain. No, two, Pare Hospital and Maluti. I don't know the others. Honestly, those are the ones that I know they've got chaplains. And therefore, it means somebody can be given or referred to a chaplain or pastoral care for the support, so that they can still have hope and meaning of life. And because when people are unwell and they are still Christians, so much is going on within them. Why me? Why now? Why God? what have I done? Is this a punishment? So they need to have that kind of support and a hand that holds them. That's why Starlight would be providing a 24-hour care line to support and also to do home visit to help those that are in need. So we all need to be able to explore patients' needs, do within the means we have to support their physical needs, psychological, and all the dimensions in as much as we can, and escalate wherever possible.
Okay.
Next slide, please.
Thank you so much.
Okay.
Scott is saying they also have a chaplain. Scott.
Oh, thank you.
Yes. Thank you so much,
Good, good.
for letting us know. So over to you, Tebello.
And this is the total pain model I was referring to earlier, which is being founded by Dr. Cecil Saunders, and being the founder of the modern hospice movement in the 1967. And so it is actually encompassing all these issues, that it is the pain, whether it is spiritual pain, social pain, physical pain, or psychological pain. And you can clearly see the examples of what would be related to spiritual pain. It will be loss of faith, people struggling to find meaning of life again, and really being in this anxiety mode of fearing for the unknown. What is their future, the future of their children, and also asking big questions and being even frustrated and angry with God, whoever they call God. And again, it is making sure that when we approach these needs, we are coordinated. We are not fragmented in care so that we don't cross hands and overlap. Because we will be wasting a lot of resources by doing so. We don't have much in our kingdom to be duplicating jobs. But if we develop a multidisciplinary teams within district hospitals, which we are hoping after the online series that we are now doing for those that might be aware of. We did batch 1 for 100 people. We are currently running batch 2 with 120 healthcare professionals and social workers across all the 10 districts. That means when we have done the face-to-face training, we are expecting that now we move into a space of developing palliative care teams. In all the 16 states of SADC, it's only Lesotho where we haven't got the established palliative care programs countrywide. And we need to do that in our generation and time and while we are saving. Our children might be too young to make a change, our parents too old to make a change if they are still alive. It is our time, and it is the responsibility of each one of us that we can make that intentional decision to really influence change and advocate for the needs of our cancer patients in every arena where we operate from. It is by grace that we are there. And as long as now we are aware of how complex their needs are, we need to make a change. Another slide, please, Mayor. Another big challenge that is facing our nation is inadequate morphine, because it is hard for somebody to be moving from Khotlong kapo Kacha kapo Haisus Mungu just to come to Sankatana for review for a couple of doses that might not even cover the 3 months, and yet the return date to go to Bloemfontein or for the next checkup might be in 6 weeks or 8 weeks. But they need constant supply of medication to manage their pain. So these are the things that we need to review, the policies, the quota for the nation that will allow us to have adequate availability of morphine and make it accessible. And the policies that will ensure not only that we have got adequate stock, but that is the storage is correct and it is secure and safe. That is the whole journey from a supply to prescription is actually a safer one and it can be traceable. That is the whole thing that is advocated by Treat the Pain program. Many of the SADC countries are qualified for this kind of support from the American Pain Society. As a nation, we need to apply for that technical support because there's so much support that we need to even find a way of doing our own liquid morphine as a nation. Because within 30 minutes, liquid morphine has settled the pain. Even if we don't have the long-acting morphine in abundance, but at least the liquid morphine, it addresses the pain quickly. And you can have as many doses as possible, depending on the pain. So the mindset needs to change. If we look at the acronym of morphine, the mindset has to change, but that can only change with the information like the one that we are sharing now, continuing advocacy and knowledge sharing. Then we have to organize the stakeholders. That is the responsibility of MOH and its partners and stakeholders, and ensure the regulations are there. I've already done that. Procurement, healthcare, health workers, that even if the medication is in the cupboard, if we still got the restraints in our own understanding of opioids and its use, and we are still thinking of addiction, other than to think that it is intended for pain management, and anybody that has got a sensory nerves that are in pain and in agony, there's no room for addiction because the morphine goes straight to those nerves, and therefore there's no worry about the addiction. After all, if somebody has got 2 months to live, why bother about even addiction? They need to be pain-free and not to be groaning and crying all night and day. And now the initiation. The initiation is to establish those pain treatment, training people, ensuring we've got pain assessment tools that will identify the need, and then we can score patients properly and dose them properly. Then nationalization of the program. If we have piloted on 1 or 2 centers, whether it's Sankatana or Queen Mamad or anywhere, then we can now scale up the program into other districts and ensure that everybody is empowered with knowledge, and we are moving on one page. Next slide, May. Thank you very much, my dear colleagues, for allowing me this time. My words, you are likely to forget, but just listen to that small, still voice within you. That will assign you some responsibility of where your place is. Starlight is only a drop in the kingdom that is trying to push for change to address these complexities, working with our Ministry of Health, working with Sankatana and centers like Najojo in Berea, who are already doing some work to support the 4 villages in Tiwai. Now, it is our responsibility to do something in our time and generation. Nelson Mandela said, "It always seems impossible until it is done." Then the founder of Methodist Church, can you just, that slide seems to be tiny. I can't even read it now. Is it my eyes? Let me check on the other laptop. I can't read it, those words, but these are the perfect. Thank you very much. This is the code that has been guiding Starlight movement since 10 years ago. But then coming into the public 7 years ago, do all the good you can by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as ever you can. That is why I'm still having this hard cry, this hard work that has been my journey and my life for Lesotho. I'm in a privileged country where services are just here, and I've got all that I need in terms of my family being around me, not necessarily material. I'm talking about the people that I worry about when they are unwell, they are around me. But then it's about the Mosotho, the vulnerable, a child, youth, woman, and a man that is in agony day in and night, who is not able to go to any radio station to campaign for their needs, that they need paths, that they need food, that they are in pain, that they don't have money to live on. it is our responsibility as Starlight, not only to advocate, to push for education and training so that we can all be beneficiaries of this knowledge and we can apply it into our daily practice. And it is our journey to enter into the undergraduate programs to see how we can support to ensure palliative care is impregnated and is integrated into our curriculum. I'm grateful to the one that gave us time, and I'm thanking you, Mayor, for this privilege to share this moment with you all. And I have really, I'm thankful.
Okay.
It's quite emotional, but I'm grateful. Yeah.
Thank you so much, Tebello, for giving us this enlightening presentation. We hope to see you again. You need to give us more. So colleagues, thank you so much for making time to join this session. We'll meet again next week, where we'll be discussing a session relating to a topic relating to TB. Until then, keep well. Bye.
Thank you. God bless. Bye.
Bye, everyone.
Thank you.